attendees are in listen-only mode.
Good afternoon, everybody. Welcome and thanks for joining us today on our webinar presentation for Medi-Cal coverage for behavioral health treatments for autism. But before I introduce our guest speaker, I would like to just tell you a little bit about Family Voices of California and our lunchtime webinars. These presentations are statewide trainings on health and policy topics which affect children and youth with special healthcare needs. Our webinars are geared towards diverse groups such as families, professionals, parent-to-parent resource staff, and advocates. Family Voices of California is a statewide coalition of locally based parent-run centers working to make sure that children and youth with special healthcare needs receive quality healthcare. And as the state affiliate of National Family Voices, we are California's federally funded family-to-family health information center providing statewide support to families of children with special healthcare needs. So a few notes about the technology that we're using today. If you don't have a headset for your computer, you can join us by telephone by dialing in the number that you see on your attendee screen panel. And if you have any technical difficulties, just please call GoToWebinar directly at 1-800-263-6317. And owing to feedback issues, we have everybody on mute from our end. But there will be time throughout the webinar where Kristen will be answering questions, so feel free to type your questions into the little question box on the right-hand side of the menu. Today's presentation will be recorded, and what's being recorded right now, and will be posted on our Family Voices website in a couple of days. And you can actually also access archived webinars from our website. And after the presentation, you'll be emailed a very short survey to evaluate today's webinar. Thanks very much for taking the time to give us your feedback. Your input really is invaluable to us. So now it's my pleasure to introduce our guest speaker for today's webinar, Kristen Jacobson. Kristen is the founder and board chair, president and executive director of Autism Deserves Equal Coverage Foundation. Kristen has advocated for autism-related causes since 2006. In 2009, Kristen co-founded Autism Deserves Equal Coverage to help families and providers access healthcare treatment through private insurance. She also co-founded the ASD Insurance Help Yahoo group to assist parents get secure insurance coverage for autism. And through message boards and individual case advocacy, Kristen has helped hundreds of families successfully appeal insurance denials. She led a multi-year statewide effort to pass autism insurance reform in California and was a principal drafter of SB 946, signed into California law by Governor Jerry Brown in 2011. Kristen is especially proud of leading the effort that resulted in legislation included in the state budget that set California up to be the first state in the nation to implement new federal guidance about Medi-Cal autism coverage. So thanks for joining us today, Kristen, and it's my pleasure to pass the presenter role over to you. Take it away.
Thank you, Pip. I just wanted to very quickly ask if you could remind me how much time we have, because I wasn't sure if we had an hour or an hour and a half.
I'd scheduled it for an hour and a half so that people have lots of time to ask questions. We may not need all that time, but I felt more was better.
Great. That's what I thought. I just wanted to make sure, because if we only had an hour, then I'd probably take less questions. So what I'll do is I'll go sections at a time, and then I'll stop and ask if there's questions. But Pip, if you see some questions coming in that look particularly important or people aren't understanding, just interrupt me, and I'll go ahead and take a question right then.
Beautiful. Thanks. Okay.
So I'm going to be talking about Medi-Cal Behavioral Health Treatment Benefit, the new benefit that started September 15th of this year. So I'm going to just give you a little idea on the agenda of what I'm going to cover. I'm going to just give a very quick Medi-Cal 101 overview just so people understand Medi-Cal and how it relates. Then I'm going to talk about this benefit, what it covers, when, and for whom. And then most of the talk will be about how to access treatment, both with and without diagnoses, or whether you are or are not a regional center client, or you are or are not accessing behavioral health treatment at the time. So no matter which kind of person you are, there will be information for you. Also going to talk about your rights and required timeframes, and then depending on how long we have, there are some general tips that might help you down the road, but it's not, if we don't have time, we won't cover those because they're just going to be a little more down the road. But I will make sure that the presentation is available so that Pip can put it on the website, and it'll also be available on our website so that people can, if they missed it, go through. I tried to be a little more comprehensive than less on the slide so that if people went to look back, they would be able to read about it. I am going to just turn my little webcam on, and so you can see me. If it causes any problems, let me know and I'll just turn it off. All right, starting with Medi-Cal 101. Oh dear. Okay, it went back. Okay, so Medi-Cal is the Medicaid in California. So Medicaid is a federal program. Anywhere between 50 and 75% of the cost is paid for by the federal government, and then the remainder is paid for by the states. But it's a required federal program that states implement. Eligibility is primarily for low-income families, but it is also for individuals who have a disability. You might get it through institutional deeming through the regional center, or possibly through a referral from Social Security. Medi-Cal can be both primary and or secondary, and I'll talk about both those situations a little later. One of the main premises is it is the payer of last resort. So if you have other insurance, it will pay second. The one thing that's different, there's one payer after that, which would be the regional center. So the regional center is actually the payer of even further last resort. But I can explain later how that might play in. In terms of what is covered under Medi-Cal generally, there are services in the state plan. There are a number of required services that the federal government says that every state has to cover if you want the federal dollars. It's not a particularly long list. And then there is a huge list of optional services. Dental is optional. Rehabilitative services are optional. Every state defines their own plan differently, and can include however many that they want of the optional services. Then there are also some excluded services, for example, habilitative care, which has been the reason that they have tried to exclude behavioral health treatment for a long time from Medi-Cal by calling it habilitative. However, there's been some new changes, and that's what I'll talk about in terms of that behavioral health treatment is medically necessary and falls into other categories now. Waivers can cover excluded services like habilitative care. So the waiver that allows the regional centers in California to provide behavioral health treatment is under a waiver, home and community waiver for habilitative care. The other main avenue other than the state plan is EPSDT for beneficiaries under the age of 21, and I'm going to explain a lot more about what EPSDT is because that's where our behavioral health treatment benefit is falling. So what is EPSDT? EPSDT, actually maybe I'll even go to the next slide first, just so you have the definition. Okay. Early periodic screening, diagnosis, and treatment. It is the benefit that is required to be covered for all individuals under the age of 21. So beyond what's in the state plan, states for anybody under the age of 21 have to cover all early periodic screening, diagnosis, and treatment. Going back to the prior slide, the EPSDT benefit is a comprehensive benefit, and they have to cover all coverable, appropriate, and medically necessary services that are needed to correct and ameliorate health conditions, including mental health conditions. It is a very broad definition in terms of medical necessity. Anything that is correcting or ameliorating your health condition needs to be provided in EPSDT if it's medically necessary, whether or not the state plan has chosen to cover it. So what that means is, I think people will understand the dental example. Dental is an optional service. In our budget cuts, Medicaid used to cover it in our state plan. And then in the budget crisis in the last several years, adult dental was removed from our state plan. It's an optional benefit. We could remove it. But you may know that pediatric dental stayed. And that's because pediatric dental you can't cut services for kids. All mandatory and all optional services have to be covered for kids. Services must be correct, compensate for, or improve a condition, or prevent a condition from worsening. That includes maintenance of functioning, which is something that's really important for kids with autism. The only absolute limit that can be placed on EPSDT services is medical necessity. Nothing else can be limited in EPSDT. So it's a very, very broad benefit.
Could I interrupt you here, Kristen? There is a question. Will you be addressing behavioral health treatment for individuals with autism over the age of 21 during this presentation?
I can comment on it briefly when I talk about who is covered and who is not covered. Most of what I'm talking about today, unfortunately, is for individuals under the age of 21 because it's still an optional benefit over the age of 21.
Okay, thank you.
So back to the just definition. Early, the point is to assess and identify problems early. Periodic, there has to be periodic screenings at age-appropriate intervals. So it's not just something that families are required to actually bring up to their doctors. It is a proactive requirement on the part of the doctors to periodically check. Screening is the first step. There are all kinds of developmental things that would identify any potential issues. There's hearing and vision and dental screens identify issues. There's also screens like the MCAT that can identify potential risks of developmental delays.
Kristen?
Anything that's identified in
You're coming in and out. It's very wavery. I don't know if something's going on with your mic.
I will turn. That helps. It says I have a slow connection.
Yeah, it sounds better now.
Does that help?
It does.
Okay. My connection seems to go fast and slow, so I'll turn it off for a while and try again later maybe. Okay. So screening is where you identify the concern. Then diagnosis, you'd have to follow and perform a diagnostic test. And then treatment is what you would do. I don't think I have the right treatment definition. The treatment definition is on the next page. So I'll just skip to the next page then. So the T in EPSDT, until now the treatment has been missing for ASD. Treatment is the necessary healthcare services that must be made available for treatment of all physical and mental health conditions or any other condition discovered by a screening or diagnostic procedures. So anything that comes up in a screening or a diagnosis or diagnostic evaluation must be covered. The treatment for it must be covered. So autism has been left out entirely of the T in EPSDT, and that's what we were able to get this year was, I mean, you could get some speech or occupational therapy, but the most evidence-based treatment for autism spectrum disorder is behavioral health treatment, which was previously not available. So what changed? The new behavioral health treatment benefit. So in June, we didn't get exactly what we wanted. We wanted an affirmative requirement to start covering behavioral health treatment now, but what we were able to get, and what ended up being just about as good, was a requirement that we would cover behavioral health treatment when it was federally required. And 7 days later, CMS, which is the Centers for Medicare and Medicaid Services, it's the federal organization, they issued guidance on July 7th saying that behavioral health treatment, including ABA, is coverable. And they gave two different options for how it could be covered. It could be covered as a preventive service, and it could be covered as an other licensed provider service. Preventive services are very broad and include anything that could even prevent any sort of disability. Those two options are there because, as most people know, behavioral health treatment is provided by nationally certified providers. They're called board certified behavior analysts, and in many states they're not licensed. And there was a new clarification in federal regulation that said that preventative services, while they need to be prescribed by a licensed provider like a physician or a licensed psychologist, that they could be delivered by a non-licensed provider, which would be the board-certified behavior analyst. So that option applies to really any state that doesn't license their behavior analysts. Other states that do license their behavior analysts can include it in other licensed providers. Those are both optional categories of Medicaid coverage that are required for children under the age of 21. And then there was a reminder in the guidance that this EPSDT benefit requires all coverable treatments when they're medically necessary. So the federal government said behavioral health treatment is coverable, and here's how. And if it's coverable, it's mandatory under EPSDT for those up to age 21. And so therefore my conclusion is, and our state's conclusion and our regional CMS conclusion is that behavioral health treatment is required when it's medically necessary. Unfortunately, preventive services and other licensed provider services are still in the optional category for adults over the age of 21, so that population at this point is not helped. You can still get those services if you're a regional center client through the waivers. But if you are not a regional center client and you are over the age of 21, you are at this point on Medi-Cal unable to get the treatment. We do hope that over time we will be able to get that changed. The one option that any adult has who's over the age of 21 today would be to buy a plan on the exchange. But many people on Medi-Cal wouldn't have the means to be able to buy a separate plan. And unfortunately, if you're eligible for Medi-Cal, you're not eligible for subsidies on the exchange. All the exchange plans do cover behavioral health treatment for any age. So if you are over the age of 21 and you have any ability to afford an individual plan, you could get behavioral health treatment that way. And certainly the cost of the behavioral health treatment would far exceed the cost of the premiums. And when you get a plan, you would just look at, assume you're going to max your out-of-pocket, because usually when you're getting behavioral health treatment, even at a focused level that an adult might use, it would likely have co-pays high enough. And then you just need to look at the total premium and the total copay and choose the plan that is the lowest cost. In terms of who can access the benefit, the way the guidance is written right now, it says any ASD diagnosis, which would be DSM-4 or DSM-5, include autism, Asperger's, PDD-NOS, the new autism spectrum disorder. If you look at federal law, you cannot discriminate on the basis of a diagnosis if something is medically necessary for a child. So if you have a need for behavioral services, behavioral health treatment, and you don't have an ASD diagnosis, but your needs were identified in the screenings that you went to your primary care doctor for, which would undoubtedly be the case, you should not be denied behavioral health treatment. You will likely need to appeal, and certainly those are cases that I would be interested in hearing about and helping when I can. You definitely do not need to be re-diagnosed. And then, as we already discussed, you do have to be under the age of 21. What treatment can I get? Behavioral health treatment is defined exactly the same as it is in the Health and Safety Code. There's a typo there. It's 1374.73. There we go, which is the autism mandate for private insurance. And that definition is behavioral health treatment means professional services and treatment programs, including but not limited to ABA and other evidence-based behavior intervention programs. So it's not only ABA, it's social skills groups, it's cognitive behavior therapy, it's any behavioral health treatment that is evidence-based and medically necessary. And then the standard is that develop or restore to the maximum extent practicable the functioning of an individual with ASD. And as I said, you can't discriminate, so someone with another developmental disability who needs behavioral health treatment should also be able to get it. And as I read to you earlier, the EPSDT requirement requires maintenance of function as well. That word maintenance is not currently in the definitions that the that DHCS has sent to for approval, but so it may require, again, not something may require appeals, but that's definitely another area that I would be interested in assisting with if people ever get denials that something is for maintenance, because preventative treatment requires, prevention of future disability, which certainly could include maintenance, and maintenance is a very legitimate goal, depending on the circumstances. There's also a statement that they have made that BHT services are based on reliable evidence and are not experimental. So there can be no experimental denials for behavioral health treatment services. When can I get treatment? Now. The benefit is retroactive to July 1st, but it started September 15th. Which means that it's past September 15th, it started, you can get it. And I'm going to talk about how to access it, but it absolutely can be accessed now. For a small number of individuals, it may be possible to get retroactive reimbursement back to July of 2014, but I am not expecting that there are very many people who actually accessed it and would get reimbursement. Pip, are there any more questions now? That's the Medicaid kind of 101 and what the benefit is, and then I'm going to next turn to how to access the benefit.
No more questions at this point.
Okay. So I'm going to start with how to access care pre-diagnosis. So for anyone out there who already has a diagnosis, this isn't necessarily a section that's relevant for you, but we need to get the people who don't have diagnoses yet caught up to where you are. The first thing to do is to make a primary care appointment. The maximum that you can wait for that is 10 days. Raise concerns with your doctor. Ask for a developmental screening and ask for a referral for a diagnostic evaluation. You know, if you have legitimate concerns about your child's development, you know, very likely, you know, parental intuition is usually quite right. Ask for a screening, and it's likely going to confirm what you think. By the way, I know that there, or I hope that there are also some, you know, advocates and other, maybe other family resource centers on the presentation or on this webinar. Any information that I'm passing on to families, hopefully can also, you can provide this to families who contact you about how to access this benefit. And who you're going to start with is your primary care physician. Then after you get that referral, make a diagnostic evaluation appointment. The plan has to provide you the specialists. It's not your job to go find a specialist. They have to provide it. And the maximum you can wait is 10 days. It's possible, there's a little bit of flexibility here. 10 days is the most you can wait for a mental health appointment, and a lot of these people would be mental health providers. They also may be considered specialists, in which case they might argue that you need to wait 15 days. Either way, that's not a hugely meaningful difference. A lot of the wait times, though, for these appointments are, you know, 6 months to a year. That is not your problem, and you do not have to wait 6 months to a year. You cannot be made to wait more than 10 days. If they don't have a provider that can see you in that time frame, they have to provide you a provider. They have to go and take your provider if you find one. But they have to find the providers. I think this is going to be a huge issue because I think there is just an enormous shortage of providers. You know, but it's something that we're going to have to wait and see about. The diagnostic evaluation should be according to professional standards and include testing, observation, interviews, and a DSM, which is the Diagnostic Statistical Manual Review, which is where the autism diagnosis would be housed. And then you should request a written report including the diagnosis, whatever it is, and treatment recommendations or prescription. If you have a diagnosis already, then you just need to get a prescription. You should be able to get that from your primary care doctor. Either way, in the end, what you need is a diagnosis and a prescription.
Kristen, I do have around this point, I do have a question.
Great.
Somebody is saying that they're confused about whether, are you saying that ASD and an ASD evaluation and treatment can be done through EPSDT, and what does that mean for a place like Alameda County where most of the kids are on Alameda Alliance and they have a contract with Beacon to provide these services?
I don't know if, I mean, it may mean that you then need to go to Beacon. I don't know if Beacon, I think they do diagnostic evaluations. I personally think we're going to have a huge problem. There's probably 8 or 10 plans around the state that have exclusively contracted with Beacon to provide these services, and I don't think Beacon even remotely has the capacity to be able to handle the volume. I'm not sure we quite have the capacity in the entire state, but certainly if it's exclusive to Beacon, I would be very surprised. The bottom line is the plan has 10 days to get you this appointment, or maybe 15. If they can't get it, you can find a provider that you want that can take you, and they have to pay for it. You're going to need, I talk a little bit later because you're going to need to get an out-of-network referral. This is probably an area where we're going to need a lot of people to appeal. If you're not getting appointments, if you're told you can have one in 6 months or you can have one in a year, anything past 15 days, we need to be filing appeals and letting the Department of Healthcare Services know about the problems and the health plans know about the problems. Otherwise, we're going to have kids with significant delays in getting treatment. This is probably the area that we're most concerned about in terms of being a barrier to care. And I'm trying to think if I have another slide on it. Let me just look ahead. Okay, I'm going to talk a little bit about this right now. Because of the shortage, if you can't get an appointment, I believe we need to be requesting treatment prior to the diagnostic evaluation. The American Academy of Pediatrics recommends initiation into intensive treatment as soon as the diagnosis is seriously considered rather than waiting for a definitive diagnosis. In private plans, that works that way. The preliminary diagnosis by a primary care physician or a mental health provider, it counts until the diagnostic evaluation is complete. I am not saying that the kids in Medi-Cal don't need comprehensive diagnostic evaluations. They do, they're entitled to it, but care should not be contingent on having one if they don't have capacity to get one within the 10 to 15 days. And Medi-Cal EPSDT requires necessary healthcare services for conditions discovered by any screening or diagnosis. But if you fail a screening, an MCHAT, and it identifies suspected autism, that's when you should start treatment, and that would be the EPSDT requirement. We are going to have to be very vigilant and let people know and file complaints. And I'll talk later about how to file complaints. It's not that hard. You just have to do it, call, and say, I am appealing this, and get a number, a reference number. But this is going to be a big, big problem. And kids need to start treatment immediately, intensive treatment. We're putting in comments on this issue. It's one that they haven't changed yet. We really hope we don't end up in a position where we have to litigate it. We're going to hope that we'll be able to get DHCS and CMS to understand that this would violate EPSDT if they're going to require this comprehensive diagnostic evaluation and then be unable to provide it within timely access standards. So that's the that's how you get the diagnosis and the treatment recommendations. Then you take the treatment recommendations. If you're using a network provider, they should be submitting them to the health plan. And the health plan only has 5 days to reply. Again, if they don't reply in 5 days, that's considered a denial. And if you call an appeal, usually then a decision will come out. Unfortunately, we're still having to be quite vigilant in holding the health plans to the standards that are mandated in our state law. But they only have 5 days to reply. And if 5 days have gone by, call an appeal and demand an answer. At that point, once they approve it, any time along the way that they deny it, then we'll talk about an appeal. But assuming that then they approve it, they have to initiate and provide you a list of behavioral health treatment providers, which would be a qualified autism service provider that I'll define a little bit later. This time, the maximum wait time is 10 days. It's a mental health condition. This is a mental health provider. They have to find one if they don't have one.
Could I interrupt you at this point, Kristen? The attendee that you were, who was talking about the Beacon, the Alameda Alliance, she's just saying that there's some confusion there. What she was asking is if you have an EPSDT treatment program, she's saying, are we allowed now to see kids who we suspect have ASD even if the health plan is providing the service through Beacon? We were not allowed to previously see these kids through EPSDT who we thought might have ASD and not other diagnosable issues. She says that, and so there's confusion around this whole health plan. Do you understand that question?
I think so. I don't know if it's possible for you to unmute her so she could ask.
Yes, it is. Let me try that. Hold on. Okay, Sue, you're unmuted. Can you ask your question to Kristen? Can you hear us, Sue? Okay.
Well, I can try to answer it because maybe she doesn't realize her phone's on mute. You can leave her unmuted, and if she happens to figure out, and if I'm not answering quite the right question.
Okay.
So to me, it goes back to, and I'm assuming she might be talking about some younger kids. You know, my personal view on this is if there is suspected autism, regardless of whether there's an appointment for a diagnostic evaluation in 10 days, or even if the diagnostic evaluation says, you know, highly suspected autism or highly at risk for autism but too soon to diagnose, that child needs behavioral health treatment according to the standard of care. And that child should be eligible for behavioral health treatment under Medi-Cal. I don't know whether Beacon's going to allow it. If they're not, it should absolutely be appealed. To me, this is a huge, huge issue. If you look at the regional center system, the Early Start program, in their 0 to 3, I emailed with the DDS a couple of weeks ago just to get the statistics on this. You know, they have 30,000 kids in Early Start that they're obviously providing a huge array of services for. Not all have autism, but a large number of them have suspected autism. But only 3% of that population has any sort of developmental disability diagnosis, and yet there are hundreds, if not thousands, of kids getting behavioral health treatment and ABA through the regional centers. It's really strong evidence of the whole idea that treatment needs to be started as soon as you have suspected autism and not wait for a definitive diagnosis. That's the standard of care. What the regional centers are doing is what private insurance should be doing, and it's what Medicaid should be doing. I can highly expect that Beacon is still going to say that's not okay, and then you should appeal it and you should call me about it, because this is definitely an issue that I would really like to work on. It's in our statutes that it's required. It's in federal law that it's required. It's the standard of care, but I don't know that they're going to apply it properly and provide the treatment without a fight. I hope they will. Because these kids clearly need the treatment. The regional center is an obvious, you know, the Early Start program, that's the whole idea. EPSDT and Early Start are very, very similar concepts. You treat early, and you may even avoid ever getting the diagnosis. And that is an ideal outcome, and that's what you're entitled to under EPSDT. So I don't know if that answered the question, but hopefully it did.
Yeah, Sue's been trying to speak to us, but we can't hear her for some reason.
Okay.
Just while we're on that subject, another question came in while it says, our Medi-Cal providers do not have any providers to provide the service, so how can people access the service immediately?
They don't. They are building their networks. I mean, not to defend them, but a little bit on this point to defend them. You know, DHCS had been telling everybody, you know, for 2 years or 3 years that we've been talking to them that this is not covered and we're not doing it and you're not going to have to do it. And then when this federal guidance came out, there was pretty much a complete about-face, and they said, and you have to do it, and by the way, you have to start in 5 days. So the health plans do not have providers, but that is not the family's problem. That's the health plan's problem, and it's DHCS's problem. Anyone who can find any provider, if the health plan doesn't have one, they have to either find you one that's out of network or take yours. They can't. The obligation doesn't go away. The family still gets treatment. I don't mean to put the burden on the family to find a provider, but probably right now, given how completely inadequate the networks are because they're just starting to build them, you know, the best thing to do for a family is to go find a provider that can see them and then get their health plan to do a single case agreement with that provider for their care. and they have to do it. They don't have any choice unless they can come up with another provider that has availability immediately. So, you know, if they do, great, but if they don't, then they have to just take the provider that you find.
Okay.
In the first part of getting the provision, at the bottom of that middle box, they're going to develop the treatment plan. They're going to document the strengths, the deficits, put measurable and achievable goals, and recommend the frequency, duration of the treatment and the supervision. So make sure that if your provider, if you have a provider and you're at the point of getting a treatment plan, that they have all of these things in it. And then that's going to be recommended to the health plan. So then if they are in network, they should submit it. If they're not in network, you might have to submit it. Even if you're not in network, they might still have to submit it. You're going to need to talk to your health plan to figure out, how do I get you this? And they're going to have a process for you. People are going to need to be a little bit patient because there are not processes in place. They did not, you know, even on the private side, it was slow and difficult, and they had 6 months to prepare, and these plans didn't. So, but again, once it's submitted, they have 5 days to reply, and the treatment has to begin within 10 days of the authorization. They have to be able to find you an appointment immediately. So this idea that Beacon's going to make you wait, or there's just nobody in network at all, that's not your problem. You're entitled to treatment within 10 days. At least getting your initial appointment. But it doesn't work to get your initial appointment and then they say, but the rest of your treatment can't start for 30 days. No, your treatment needs to start to meet timely access requirements. Other requirements, you're going to need a prescription. So either the person who does the diagnosis or somebody different, but a physician or a licensed psychologist, not a BCBA unless they are also a licensed psychologist, or really only those two, physicians or licensed psychologists, have to give a prescription. The provider is the same as the private insurance mandates. Qualified autism service provider is the supervisor. That is somebody who's licensed. They can be a speech therapist, an OT, a clinical social worker, a marriage and family therapist. Sometimes the speech and OT people have a harder time with the health plans. The most common supervisor is going to be the board-certified behavior analyst, either a master's level or a doctorate level. And then there are 2 tiers below them. They are going to supervise the qualified autism service professionals and paraprofessionals. All the treatment does not have to be done by the top level. It is a tiered model. Hopefully they'll use a 3-tiered model. Some might use a 2-tiered model. But it's definitely a tiered model. Parent participation definitely helps to maximize outcomes and should be provided to the maximum extent possible. Parents are entitled to parent training. That should be a part of the treatment plan. I think it's critical that it cannot be required to the extent that it limits access to care. If you have 2 working parents, you can't, the health plan then can't refuse to provide treatment because the parent isn't able to participate in 100% of the care. Participating in 100% of the treatment is not a reasonable requirement. There's all different levels of parent participation. It might be participating in a clinic meeting once a week, once a month, depending on what's, you know, clinically appropriate. It should be defined as what's appropriate for the child and not on any sort of arbitrary requirements. But I can see an issue could come up around this because you have a lot of 2 parent working families or people with multiple jobs, and that can't be a barrier to accessing care.
So going back to that slide, Kristen, there's a question from Sue saying that they were told by Beacon that they would not be able to contract with developmental pediatricians, only child psychiatrists or psychologists for assessment and diagnosis. And then she went on to say it seems strange, so strange as developmental pediatricians are the best trained to make these diagnoses. Is there anything in federal law or any way to advocate to change that?
It's the first I've heard of it. I would have a hard time saying, understanding what their rationale could be. I mean, if they have psychiatrists and psychologists that are qualified and abundant to make the diagnoses, fine. But some people might need a developmental pediatrician. Certainly, they're some of, I think, oftentimes the most competent to make these. I think you could try to make a medical necessity argument to say it's medically necessary for this patient to see a developmental pediatrician. I can't imagine that they can actually categorically exclude a type of provider and say you can't use that type of provider. I would actually think the obligation is more the other way around, that they have to have that type of provider. When I was, their network adequacy requirements are the same as private insurance. And so when I needed a developmental pediatrician and Blue Shield didn't have one, they had to pay for the developmental pediatrician that I found. They may try to argue that a psychiatrist is equally efficacious. If it is for that particular child, then that's okay. If it's not, and that child needs to see a developmental pediatrician, then they're going to need to find one. You may have to appeal. But I definitely, maybe Sue, you can contact me offline, because I know you weren't able to sort of voice your concerns, over the email. But, I have a lot of concerns about anything, all these exclusives with Beacon or any sort of categorical requirements or limits are not legal. They have to be based on an individual. They cannot say you can't use a developmental pediatrician.
I'll send your email to Sue after the webinar.
Okay. Any other questions on this, or can I move on?
There was one from Krista. She was asking, while in that process of waiting to, if you're in an appeal process, should the regional centre cover services while that process is going on, if their children are clients of regional centre?
If you're a client, I'll talk about clients of the regional center. The first thing is that if you're a client of the regional center and you're getting services, you're entitled to keep them for right now, and you don't have to change. You will have to change later. But if you are a client of the regional center and you're having to appeal and you're not getting them yet through insurance, the regional center is obligated. I mean, if it is a service that is needed on the child's IPP, even if Medicaid is supposed to be covering it, if they're not, the regional center is the true provider of last resort. So I would definitely be asking them. And for any child who's a regional center client who ends up getting services through Medicaid, they should stay on their IPP, or they should be put on their IPP and just put that the provider is Medicaid. And then if the provider ever goes away, maybe they switch, maybe they end up not being on Medicaid and switching to an employer plan at some point that doesn't cover behavioral health treatment. It's on the IPP, and the regional center would be responsible. So the only reason the regional center can't pay for it is if Medi-Cal is. But if Medi-Cal isn't and it's needed, then they should be paying.
Okay. And on the same slide, there's one of our attendees is a provider and is wondering if in the scenario that the carriers don't have an in-network provider to serve and the family finds an agency they'd like to go with, if the carriers would have to provide services under the provider's terms, i.e., rates, or if it would be a single service agreement under the carrier's terms.
It's going to be a negotiation. It can go both ways. I mean, it could be under the carrier's terms. If you won't take, if you as a provider won't take them, but another provider will, then they can definitely use their terms. If no one's taking their terms and there isn't another provider, then you have a lot more negotiating power. In the end, they have to provide services to this family. So they're going to have to pay whatever rate is necessary to get adequate, to get a network, to get a provider for that family. So it's not a complete black and white answer, but it is, it is an area where you definitely, you have leverage. In the end, they're required to pay what it takes to get the child treatment. But if someone else comes along that can do it and will do it for their rate, then they don't have the family doesn't have the choice to choose somebody else when they have a provider that could do it. But generally, right now, they're not going to have providers, or a lot of them won't.
Okay, thanks. The person asking that said super. Thanks very much.
Okay. We've already talked about the comprehensive diagnostic evaluation. We're absolutely wanting kids to get it. It should include all of these things listed here. Right now they're saying no more than 4 hours to do this. What they want can't be done in 4 hours, so that's going to be something that might get worked out. But children are entitled to comprehensive diagnostic evaluations. I just don't want them to prevent someone from getting treatment if they can't get one, or if in the end what they have is highly at risk for autism and they still need treatment. That might have come out of the diagnostic evaluation. The diagnosis doesn't limit the ability to get it. I'm going to talk about a couple issues right now that are, this one is hopefully not going to be an issue. The initial, things are moving really, really fast right now. So September 15th, the Department of Healthcare Services sent out an all-plan letter to all the health plans and said, here's the benefit, here's what's required. In that, they sent out something that said that only those who exhibit the presence of excess and or deficits of behaviors that significantly interfere with home and community activities were eligible for treatment. And they did broaden the list. It used to just say, self-aggression, self-injury, and elopement. They did add social interaction, independent living, play, communication skills, which definitely helped. But right now the language still says significantly interfere with. That would violate EPSDT. It is anything that ameliorates the deficit of the condition. And it doesn't, the significantly interfere standard is not an appropriate standard. When they then 15 days later put their state plan amendment in for federal approval, they did remove the significantly interfere language. So I think they've backed off that language and they've acknowledged that that's a problem and it would violate EPSDT. But some of the health plans may still cite that initial all-plan letter and you try to deny it, in which case that's definitely one where you would want to file an appeal and contact the Department of Healthcare Services so that they can make sure that the plans are educated. Stuff is just moving so quickly that I believe that this was changed, but there's no new all-plan letter out there. The only paper is what was sent at that point. There is particularly a vocational, recreational, and particularly a custodial exclusion. And so I want to make sure particularly that both families and providers really understand what that excludes. It excludes actual custodial care, which would be doing the activities for them. It would be bathing them. It would be, brushing their teeth. That is different than what behavioral health treatment is, which is to build skills toward independence and treat the core deficits of autism. It is not education, recreation, vocation, or custodial care, even if some of the goals may address some of those issues. So if you make sure that the goals focus on communication, social, repetitive behaviors, aggression, attention to task, joint attention, flexibility, skill acquisition, should say, etc., any of the deficits of autism, that's medically necessary and that's not educational, recreational, vocational, or custodial. And it's kind of important to emphasize, to de-emphasize the tool that's being used. The treatment is medical treatment. They may use a ball to work on joint attention. That doesn't mean it's just about playing. Or they may use a book to do something, or a toothbrush, but that doesn't mean that it's by definition custodial because it uses a toothbrush. So custodial care, it's not custodial care because it, hang on, I don't want it to imply, custodial care is not teaching, hopefully the slide's not confusing. Behavioral health treatment is teaching skills to develop activities of daily living for independence. That's treatment. Doing the activities of daily living for the child is custodial. Make sure the ABA is focused on the skill building. And I'm just going to BHT is, just so that that's not a confusing slide. Location of service denials, medical versus educational. This should be less of an issue with Medicaid than it is in private health insurance. Medicaid, I believe, Department of Health Care Services, they acknowledge that there's no issue about providing services on a school site. They reimburse LEAs, which are school districts, directly for providing medically necessary services. So the issue may not be as much of a problem. However, the health plans may still try to prevent it because they are worried, you know, because they're trying to prevent it for the private plans, which is also not appropriate, but, you know, they may just have things in place and tell providers you can't provide it on a school site or you can't provide it during this time of day. That's just not true. Location of service denials are not appropriate. The treatment should be driven by the goals and the end goal of a specific intervention. You're treating core deficits, that's treatment, versus state curriculum or subject matter, that's education. So medical treatment remediates signs, symptoms, and disabling effects of autism. Education accesses education equally to that of a non-disabled peer. IDEA, which is the federal special ed law, is often misused to deny medical necessity by health plans. Service delivery might be a very integral part of a treatment plan. Generalization is critical and has to happen across locations. And social goals often are most appropriately met in the school setting with peers. Also, 40-hour-a-week studies that are published in medical journals, they always or often include multiple settings, including school. So they should not be denying treatment based on location of service. They should not be telling you you can't recommend or have treatment at school. That would be a categorical denial that would very much violate EPSDT. It's very important as a provider and as a family that you ask your provider to make sure they make the recommendations. If you need 40 hours across settings, make the recommendations, ask for that, and let them deny it. If we just give in and don't even recommend it because they say it's not covered, then there's no chance to even argue this point because they'll say, well, we're not denying it, no one's even asking for it. You have to ask for it. This is not to say that the school isn't responsible. This kind of tries to show school and insurance how the overlap is. And there's, you know, the part on the left in red, that might be insurance only, and it might address core deficits that have no impact at all on the ability to access education. Maybe a child is aggressive at home to siblings, but never shows any aggression at school. That would really be insurance only. And on the right, there are clearly going to be some academic goals to reach grade level that are only school related. But there's a very big portion in the middle that is actually the responsibility of both. For example, ABA at home, even for a 3-year-old. It may be necessary to access education. Often, you know, it's often the case in young kids. It's also very much medically necessary to, you know, ameliorate the symptoms of their condition. Or ABA at school that's addressing core deficits, but it's also necessary to access the education. Those two big buckets are in the center. Ideally, insurance would actually pay for the treatment, and then the school would pay for the copay and the deductible. For that to happen, the service needs to be on the IEP, and it needs to be authorized by insurance. If insurance doesn't cover it at all, you might, up until this point, Medi-Cal didn't, then the school should pay the entire cost. Obviously, some schools are better than others in actually meeting their obligation, but the bottom line is that both entities have an obligation, and neither one can use the other to say, well, they should be responsible. They're both responsible, and what I'm finding now on the private side is I'm starting to win more and more cases pretty consistently now, saying that the insurance company has to pay, but the health plan, the school then is refusing to let the providers on campus. It's a very tricky issue. We are working on it. It makes absolutely no sense. The school boards lobbied and advocated to get SB 946 in place. And it doesn't make any sense for them to then refuse the treatment. And we think they're also violating, IDEA and American with Disabilities Act rules and laws. But that's going to have to be addressed on a more systematic basis. If people, have cases that are in there where the insurance company, you've gotten it determined that it's medically necessary and the school's not letting the provider on, those are ones I definitely like to know about, because we're really trying to come up with a statewide strategy to address that. Information that you shouldn't necessarily be providing to Medi-Cal or any other insurer. The IEP is a confidential educational document, and it often does not have bearing on medical necessity. Providers certainly don't have the right to release it without you, but it's confidential information and it's protected, and you don't have to release it. Medicaid does have an obligation to coordinate care, but they also have an obligation that whether they're providing something, it doesn't matter if it's duplicative to school, they still have to provide it. So there's really nothing. A lot of them will try to use the IEP to say, well, you're getting it already, but they have an affirmative obligation to provide what's medically necessary, even if it's duplicative of something that's happening at school. The standards are different and higher. Other reports, some health plans are saying, well, we need to see everything under the sun, autism diagnosis, OT speech, vision reports. If it's readily available and it contains information that's relevant to behavioral health treatment, go ahead and share it if you want. But it's confidential, protected information. You don't need to share it, and you don't need to have it in order to access behavioral health treatment. An OT evaluation is not necessary to figure out whether behavioral health treatment is needed. A behavioral health treatment evaluation is necessary. These plans are asking for a lot of information that isn't necessary. Ask them to put it in writing. Sometimes it will go away. Also, you can appeal and say this is not necessary. Make a decision based on what you have. And if you've provided the diagnosis, the treatment plan with the goals, and the prescription, that's really all they should need. Okay, appeal rights. You have the right to complain about any part of your child's services. You would first file a complaint with the actual health plan. If that doesn't work, then you would ask for an independent medical review, and all the information is there with phone numbers and complaints. If your needs are urgent, you should ask it to be expedited. And frankly, almost all children not receiving behavioral health treatment for autism are urgent and are treated as urgent expedited cases by the Department of Managed Health Care. You also can ask for a state fair hearing through the Department of Social Services, and the information is there. Medi-Cal recipients have the choice after they do the appeal with the health plan. They have a choice of independent medical review or state fair hearing. I highly recommend the independent medical review. It's easier. The lawyers are provided for you. You don't need a lawyer. It's decided by a doctor instead of an attorney. You do potentially have to choose which route you're going to go, and one route may preclude the other. I believe if you I can't be sure on this. I think if you ask for a state fair hearing, you're done. If you ask for an independent medical review and you don't like the outcome, you can still appeal, I think, to a state fair hearing. You do need to check, though, one of the two precludes the ability to get the other. And then I would say always contact Department of Health Care Services. Anytime you hit a snag, they need to hear about the problems. Of course, you're going to have to call your health plan and deal with your health plan, but always send an email to the ABA info email and copy this Medi-Cal autism benefit. That's an email I set up just for this case. I don't reply. You'll get a message saying that I don't reply to those, but I want to be able to track as much as possible what's going to DHCS so we can know and hold them accountable.
While you are still on the appeals process, Kristen, one of our attendees is asking, when there's only provider listed in when there is only provider listed on an insurance plan, for example, Children's Hospital Oakland, and the wait for an appointment is upwards to 6 to 12 months, can you appeal for gap coverage, like to see an out-of-network provider?
Absolutely. As I said before, they actually only have 15 days at the most for a specialist appointment, or 10 if it's considered a mental health. 6 to 12 months is nowhere in that. Children's Hospital Oakland is an excellent example because they're the only diagnostic center, I think, in that area that is a Medi-Cal provider. You shouldn't even have to appeal to get an out-of-network referral. You should ask for one, but if you're not given one, then you should definitely appeal. And definitely copy the ABA info line, because we've been telling them this is going to be a huge problem, and they need to hear it if it is, and they need to see. And people need to know their rights, that if they're told it's a 6 to 12 month waiting list, that that's appealable. That is absolutely not okay. They have 15 days. And it has to be within 15 miles of your home, 30 minutes. It's a mental health issue, and so all of the really good timely access and network adequacy requirements. So they can't, maybe for a specialty appointment they can ask you to go a little farther, but it's a mental health appointment with a child who likely has autism, who, going an hour in a car is not going to be appropriate in many, many cases.
And is that 15 working days or regular days?
I think it's 15 calendar days.
Okay.
I will have to check that, though. It could be business days.
Okay, another question on the same lines. If you have self-funded insurance and your current plan does not provide ABA, although they do cover through a Kaiser plan, but this person must wait until open enrollment in April, can I still file for Medi-Cal?
If you're eligible for Medi-Cal, I believe you can join Medi-Cal at any time. I am not an expert on how to get on Medi-Cal. There are probably other people that are better at that than me. But my understanding is if you qualify for Medi-Cal, you can get a Medi-Cal plan, and then the benefit would start right away. You also could look at a Covered California plan. I don't know, I can't remember when exactly open enrollment stops.
I think the 15th of this month, isn't it?
Yeah, I think the 15th of this month.
So my understanding is you can enroll for Medi-Cal anytime.
Yeah, I think you can enroll for Medi-Cal anytime, and then Covered California for another 15 days or less, I guess.
And while we're on this slide, is that the IMR is the final deciding factor document, right?
The independent medical review, what that is, it's an external review by a doctor who is a specialist, supposed to be a specialist in the area. So often they're done by pediatric neurologists or developmental pediatricians. And you get to put in, your arguments about why you think it's a medically necessary treatment. Your provider should work with you and put in their arguments. I have a whole nother, presentation about how to prepare for independent medical review, and then they will give you a decision back and it's binding on the plan. And as I said, for kids who are not in treatment for behavioral health treatment, I have found that the DMHC, which is the Department of Managed Healthcare, which is the one that you complain to, that they've expedited all the complaints for any child with autism not getting treatment, in which case, you know, it shortens the appeal from 30 days to 3 with the health plan, and then a week with the independent medical review compared to another 30 days. So it really dramatically can shorten the time frame. So I think, you know, the state declared that any denial or delay of behavioral health treatment for autism would likely cause irreparable harm, and DMHC filed emergency regulations about that in 2012. So they would have a very hard time at this point not expediting any request about a child not getting behavioral health treatment.
Okay, thanks.
Okay, so what if you're a regional center client? This is another part of the CMS guidance that I don't think any of us were really expecting, and is kind of tricky. Now that behavioral health treatment is an EPSDT service, it cannot be offered through a Medicaid waiver, which are the regional center waivers. For people that are familiar with the numbers, it's the 1915C, which is institutional deeming, or 1915I. For over 21, the waivers are still fine because those services are not available in our state plan. So if you're over 21 and a regional center client, you can still get services through the waiver. It is important, though, that if you're a regional center client who is currently, right now, you're going to get to keep and stay with the regional center. But at some point, you're going to have to transition to Medi-Cal. When that happens, if you're institutionally deemed and your whole eligibility for Medi-Cal comes from being on this waiver, you need to make sure that you maintain eligibility for the waiver and therefore Medi-Cal overall, even when the behavioral health treatment is moved to Medi-Cal. Usually the requirement is that you're receiving at least one waiver service. And if you don't receive a waiver service, then you would potentially lose your eligibility for Medi-Cal entirely. Respite is the most likely service, or durable medical equipment. Could be diapers if those are still allowed. You need some service from the waiver if your eligibility for Medi-Cal is based on a disability and institutional deeming. You need to maintain a waiver service, and once the transition happens, you will not be able to have that service be behavioral health treatment. So who provides your treatment now? If you entered the system, the regional center system, and that means walk in the door in any way, be part of during the intake, or 2 months in, or 2 days in. If you walk in before September 15th, those, hang on, I really need to change that slide because that is really going to confuse people. That is a typo. It's what happens when you finish something at 1 in the morning. Before September 15th of this year, you can stay with the regional center. You may transition to Medi-Cal at any time. So if you don't think you're getting enough service, or you don't like your provider and you want to transition to Medi-Cal, you can do it any time. But you can also stay with the regional center for the sort of midterm foreseeable future. If you enter the regional center system after September 15th, you have to go to Medi-Cal. I would say the one thing that might be different from that is if you're denied through Medi-Cal, or you're just not able to navigate the system, then you may be able to get it from the regional center in the interim. But I imagine that they may give you some grief about it, but you should be able to win at that. They're ultimately responsible if you're not getting treatment and you need it. Who will eventually provide the treatment? They are developing a transition plan. There are 7,500 to 7,700 kids in the regional centers that are going to have to transition to Medi-Cal. We don't know exactly when that's going to happen. They are developing the plan. You definitely have continuity of care rights up to a year. We want minimum a year with your same provider. at a minimum, you should be able to get a year. The provider has to be willing to contract with Medi-Cal. That's going to be the one thing. And if rates are set and they have an adequate network, then the provider will need to take the Medi-Cal rates. If they don't have an adequate network, then the provider can negotiate. The details are being worked out. It's really important to participate in the stakeholder meetings. The next one is going to be December 19th from 3 to 5 in Sacramento, and the details are on the website that I put there. Managed care versus fee-for-service. Managed care, we'll start with that, Medi-Cal managed care. 4.5 of the 5 million kids on Medi-Cal are in managed care, so this is the vast majority of everybody. The behavioral health treatment is going to be provided by your managed care plan. Kaiser, LA Care, San Mateo Health Plan, whoever it is. And you have to use the network providers unless there's no availability, and this is the question that keeps being asked. If there are no network providers, you may go out of network, but you should request an out-of-network referral. You can't just go out of network, and you're requesting it from your health plan. Fee-for-service Medi-Cal. About 500,000 kids are on it. I believe a fair number of the kids who are regional center clients actually and are institutionally deemed, more of them have fee-for-service, not all of them. Apparently for those, behavioral health treatment services are going to be provided by the regional centers. Medi-Cal is actually going to be subcontracting with the regional centers. It is going to be the EPSDT standards and eligibility, not the regional center standards for those kids. So if you happen to be in Medi-Cal and in fee-for-service and you're not a regional center client, you will still be able to get your behavioral health treatment through the regional center. The specialty mental health that's available through the counties, that is not relevant for the behavioral health treatment. That's not where it's going. It's going through the Medi-Cal managed care organizations and for fee-for-service through the regional centers. Does anybody have any question about that? Because certainly the whole regional center and managed care fee-for-service, those are pretty confusing. Nope. Can you still hear me?
I'm sorry. Yes, I'm sorry. I was on mute. I was on mute myself. Questions.
Okay.
There's one question from a parent, a personal question saying, I have a 17-year-old son who has Medi-Cal with Kaiser coverage. He has autism. If I get a prescription from his PCP and Kaiser isn't offering mental health services due to Medi-Cal requirements, where do I go to look for providers?
Well, Kaiser would need to be. So I guess if that person could maybe write back and clarify what do they mean by Kaiser's not offering them. I mean, they may not have been offering them before September 15th, but starting September 15th, they need to be offering those services. So if that 17-year-old is on Medi-Cal and uses a Kaiser managed care plan, behavioral health treatment and other mental health services need to be provided by Kaiser.
I think, how do you feel about sharing your email address with everybody that's attending this webinar, so that I have a feeling they have lots of questions like this that we're not going to have time to cover.
I have an email address at the end, which is info@autismdeservesequalcoverage.com. That's the best email to use. It comes to my regular inbox, but it just helps me differentiate, where they're coming from.
Okay.
That's probably the best email to give out, and it comes right to my personal inbox. And it's on my last slide with references.
Okay, so Kristen, thank you. Can you talk about specifics that primary care and specialty care providers need to write on the prescription?
Sure. I mean, it really theoretically only needs to have the diagnosis, and presumably it's an ASD diagnosis, but it also could be suspected autism diagnosis, or it could be maybe another developmental disability that needs ABA. And then they need to put behavioral health treatment. If they specifically want ABA, they should put ABA. If they have an intensity that they want, then go ahead and put that intensity down. If they don't know, if they just want to refer, you could put refer for evaluation and treatment, and then the ABA provider or the behavioral health treatment provider should be able to do an assessment and determine what intensity is appropriate. Most pediatricians will just say, a prescription for behavioral health treatment or ABA evaluation and treatment, unless they have something specific that they would like to recommend.
Okay, thank you.
Any other questions? I know there's only about 10 minutes left, so I'm going to try to buzz through a couple of these last ones, and then at least so people know what's there and they can even go look at them later.
Yeah, why don't you keep going through, and if we've got questions left over, I will email them to you and then make sure that the attendee gets your reply.
Yep, and if there's a way even to keep it open for just a little bit longer and I can just answer you, that's a lot faster for me than typing out long responses, so I don't know if that's possible.
I'm good till 1:35.
Okay.
Okay.
Well, let's see what we can do. Okay, Medi-Cal at secondary. So some people have private insurance and Medi-Cal. First point of clarification that I'm getting a lot, you do not lose your Medi-Cal if you have a secondary plan. People have been saying, and Kaiser's told people, and they've told them incorrectly and had to later take it back and apologize. You may have a secondary plan if you have Medi-Cal. It's just that Medi-Cal is secondary. The one thing is you're not going to be eligible for subsidies through the exchange if you're eligible for Medi-Cal. That is probably less of an issue now that Medi-Cal finally does cover behavioral health treatment. When it didn't, we had a lot of people trying to buy exchange plans who were on Medi-Cal just so that they could get the behavioral health treatment covered. Medi-Cal can cover cost sharing, and that would be copays, deductibles, if it's covered services, and if you use a Medi-Cal provider. It's going to be tricky when the provider networks are not adequate. So, there may be some difficulty there, but they should be paying for copays and deductibles the same way that they pay for your medication copays or your speech copays. It's a lot easier in that case usually with Kaiser because there are, Kaiser has a system set up where they're a Medi-Cal provider and they just don't even bill for the copays for some of that stuff. It's a little harder when they're using Easter seals to get that tracked, but they're going to need to figure it out because if you have Medi-Cal, now that it's a covered benefit, and if you're using a network provider or a Medi-Cal provider, then you shouldn't be paying your copays and deductibles. Okay, these are just some tips for providers or families in terms of what to ask for. Make sure you have quantifiable, measurable goals that address your core deficits, that align with the Diagnostic Manual, DSM, or the insurer's utilization management criteria. Make sure they're achievable. Put in benchmarks. Be thinking of reauthorization and documenting progress. Make sure you put a time frame and include quantifiable baseline measures so that you can show progress. This is really critical. Follow the standards of care. Do not recommend or do not ask for what you think they're going to approve. It's a vicious circle. Be research-based, use BACB standards, use physician recommendations, back it up, specify hours, duration, settings, and any extenuating circumstances. On your progress report, make sure you're demonstrating progress, and need, and maybe new goals and recommendations. Preventing early termination, use the child's own progress as evidence of effectiveness, especially if after several years. The goal is to maximize functioning, so there's no reason to stop as long as meaningful progress is being made and they either, their function's maximized or they don't have deficits. And all ages are appropriate, up to 21 for Medi-Cal. Okay, wow, I actually got through them. resources. Make sure you routinely send any problems. I'm going to be a broken record on this. abainfo@dhcs.ca.gov. Copy to Medi-Cal Autism Benefit at yahoo.com. That's me. I won't reply to those, but I'll just be tracking them. If you need a reply, write to info@autismdeservesequalcoverage.com. And then there is a link. I will put this presentation there. There's a page I have for Medi-Cal info. Right now what it has is a press release that describes what the benefit is, and it has tips for, it's a one-page tips for getting treatment. This is going to be a lot more detail, but some people may only want a one page. And the press release and the tips are translated into Spanish and Chinese, thanks to Family Voices. And so if you know of families that only speak those languages, there's at least some limited resources there. And then Family Voices has agreed to field calls in Chinese and Spanish, and their phone numbers and contact information is on those reference guides. So, and if they don't know the answer, they'll be calling me, and we'll work out how to get the answers translated back. But we're doing the best we can because we know that a lot of people who have Medi-Cal do not have English as a first language. And then the DMHC Help Center is the other number that is where you would file your IMRs. So those, I'll try to get the Medi-Cal Ombudsman number as well, because we want to make sure that there's a Medi-Cal Ombudsman that knows about these things as well. But for now, just use that ABA info email. And questions. We have, a couple of minutes, very couple of minutes for more questions. And, we're a nonprofit. Yesterday was Giving Tuesday. I was writing this presentation instead of sending out my Giving Tuesday notice, but we can do Giving Tuesday on Wednesday. So, please consider a donation so we can continue to help and do this important work on Medi-Cal. And if you go to the website there is a button to push to get to donate.
Wow, thank you, Kristen. That's such rich information, so much to take in. I'm so pleased that we've recorded this whole presentation, and your slides will be up on our website. But there are a few more questions before you go, so I hope the people who ask them are still with us. Is this for the diagnosis provider? Actually, sorry, let me go to this other one. I haven't used Medi-Cal for my daughter because her specialists are not Medi-Cal doctors. She qualifies due to SSI. We use United Healthcare through work. I would like to use Medi-Cal for prescriptions and deductibles, but I'm worried that UH will drop my daughter.
I don't believe UH is allowed to drop your daughter. If you have coverage through work that's being paid for through work, they can't kick you out. You have that coverage. If you talk to them and they think, they're implying that somehow they would do that, that's definitely something to contact the Department of Managed Health Care about. You pay premiums and you have a contract. And Kaiser tried this, and the first level person at DMHC was actually confused and thought that Kaiser was right. But as soon as I got beyond like the low level person who answered the phone, it was very clear that they're wrong. They cannot drop you because you have Medi-Cal. So anyway, they should not be able to do that.
Okay. And here's a long one. The needs for ABA have become the only source of service that is being provided by most government-funded agencies. However, not all children with autism respond well to this treatment. In fact, for some, this form of behavioral service is more damaging than no service at all. Simply put, as a parent, if ABA goes against your upbringing about how to raise a child, even one with a disability, and is insensitive to your cultural value of how children should be taught, most likely you are not going to practice this form of behavioral intervention after the behavioralist and their technicians leave. Could Medi-Cal provide an alternative form of treatment? Oops, sorry. An alternative form of treatment to help our children, preferably one that will also take into consideration natural child development and cultural sensitivity. Well, okay,
Yeah, it's very clear, actually. I mean, California is somewhere that we're lucky. A lot of the states only mandate coverage of ABA. California defines behavioral health treatment to include ABA and other evidence-based treatment modality. I personally, have found that floor time has helped a lot of kids. The Early Start Denver model is a combination of ABA and floor time. Some people prefer pivotal response training, which is more naturalistic in terms of the environment. But it's very clear that ABA is not the only evidence-based treatment for autism, and it is definitely not appropriate for all kids. So the definition in the Medicaid benefit is definitely broader than ABA, and so you should be able to access it. You will still have to prove medical necessity. I'd have to research a little further on sort of what role family values is. The treatment certainly cannot be only for the convenience of the family, but I do believe that cultural specific factors should be considered and need to be considered. I don't have the legal citation that backs that up, but the bottom line is that the definition of what's included in this benefit is definitely broader than ABA and can definitely include more developmentally rich modalities.
Fantastic. Thank you for answering that. And then I think one last question, just a clarification on that the provider writing the RX for behavioral health treatments does not need to specify more than the diagnosis code. And because this person says the pre-authorization request has spaces for service code, quantity, quality, description, etc.
Yes. So I might have misunderstood the first question. The question in terms of what needs to go on the prescription from the physician or licensed psychologist needs to be the diagnosis code and then the behavioral health treatment that you want and potentially the intensity that you want. A pre-authorization request form that a behavioral health treatment provider fills out will have to have substantially more information. It will need to include the right service codes. It'll need to include the intensity for each service code, so there might be a code for the frontline therapist for supervision, for parent training, and they may need to fill out other forms that or other pieces of information. In terms of the coding, that's a whole nother issue. We just did a webinar for providers, a two-part webinar, which it wouldn't really be any different for Medi-Cal than insurance, and that should be on the Autism Speaks website. I think the first part would answer these questions more. But the health plan, because there are not universal codes for ABA, the health plan actually has to give providers the codes that are that they use for behavioral health treatment. And they need to, and you need to make sure you know the units, because a lot of the codes are 15 minutes, and so if you put one code for an hour thinking that you're getting an hour and it's a 15-minute code, you'll get paid for 15 minutes, not for an hour. And you need to make sure your contracts also cover and have specific rates for the codes that you're going to be using, because those codes are not standard in a lot of the contracts, and so you need to have the specific autism contract so that you know what your rate is going to be for those particular codes. They did, the AMA has some new codes that they're testing for, I think they're specifically for ABA, and those codes are, apparently they have some troubles. They're optional. Not all health plans are using them, but some are. Apparently there's no code for indirect supervision, and so that's a problem. You're going to need to find another code for that. But those are interim codes. But so there's two different things. There's the prescription, and then there's the pre-authorization for behavioral health treatment, which I think is what the second question was about.
Right. Okay. Thank you. I think that we need to close the webinar for today, but I did want to remind everybody that it has been recorded, and Kristen is going to send me her PowerPoint presentation slides, so everything will be up on our Family Voices of California website in a couple of days. But I want to thank you very much, Kristen, for everything that you've done, especially your work around SB 946 and the new legislation, and to all of you for joining us today. Stay dry, and I hope that you can join our webinars in the new year, in 2015.
Thanks, Pip. Thanks so much.
Okay. Bye-bye, everybody.
Bye-bye.